Hi everyone, welcome to the Quarter 4 OMDCE. Today's sessions are going to be a continuation of our protocol update training. Hopefully you've received the draft in your email as well as the video where I go over all the changes in the document. I hope you've watched the video and have started reading through the protocol draft in anticipation of our update coming early next year. In today's sessions, we're going to cover a few things. First, I'm going to start off by doing a deeper dive into some of the bigger changes in the protocols themselves. And then we're also going to do a review of the pediatric and OB changes with some of the members of the team. I want to thank everyone for your willingness and adaptability when it comes to this new sort of CE format. You know, I'm a big believer in live CE. I really appreciate getting the FaceTime and being able to sit and really converse with a lot of you about the medicine behind our protocols. Unfortunately, with the COVID-19 pandemic, the things have had to adjust, and you guys have done a fantastic job at helping us continue to get this education out there. Please, if you have any questions, if you have any concerns, if you want to know more about any of the changes that we've made, please feel free to reach out to us. With that, let's go ahead and get started with today's sessions. All right. So here's all the things we're going to cover today. We're going to start off with some BLS sections. So we're going to cover DNRs, most pulse forms, non-invasive positive pressure ventilation and our change from CPAP to a bilevel device, as well as a reminder of the crashing patient protocols. And then we're also going to cover in the ALS section the dosing change for TXA, the addition of push dose epinephrine, and then the addition of ketorolac or Toradol as a pain management option. So let's talk a little bit about DNRs and then this new concept of a most or a pulsed form. So what's a DNR? So DNRs you're pretty much used to, right? A DNR is a legal document. It comes from the state, and in Texas state, we have a standardized out-of-hospital do not resuscitate order form or approved jewelry with the specific out-of-hospital DNR logo on it. And the thing about the out-of-hospital DNR form is it's really an all-or-nothing directive. It basically says, if I've signed this form or if I'm incapacitated and a surrogate has signed it for me, I don't want any of the following. I don't want CPR, I don't want airway management, I don't want BVM, I don't want cardioversion, defibrillation. But one of the areas where we get hung up sometimes is we assume that all of that only kicks in once someone's actually gone into cardiac arrest. And in reality, it really applies throughout their care. So again, like I mentioned in the original video, if you have a patient who is significantly bradycardic and is peri-arrest, but has an appropriately signed DNR form, then actually you're not supposed to pace those patients. So again, this is an all-or-nothing form, and it has to be officially signed and sort of filled out appropriately. But remember, it really is enforced throughout the encounter, and that actually includes all the way into the emergency department or anything that's considered an outpatient setting. The difference with what these new forms are called, they're called a most form or a medical orders on scope of treatment or a pulsed form of physician's orders on life-sustaining treatment. You may start to see these pop up, and in the protocol, we've basically now allowed you to honor a most or pulsed form. And what's the difference? So a most or pulsed form, it's not a legal document. It's actually a set of physician's orders. So this is something that goes with the patient. The patient and physician sit down and really dive through what their end-of-life wishes are, and they get detailed out into a set of orders. And the nice thing is that set of orders goes with the patient throughout all locuses of their care. So whether it's in the outpatient setting, whether it's in the clinic, in the ED, in their inpatient admission, rehab, hospice, etc., it's all the same throughout their care, whereas with the DNR, there's one for outpatient, one for inpatient, one for each facility, etc. And again, the difference with a most or pulsed form is the patient can detail out exactly what they would want. So if they didn't want CPR, but they wanted to be on a ventilator, or if they didn't want CPR, but they wanted pacing or drugs, etc., they're able to spell that out. Here's an example form that you may see. So again, they're usually branded with sort of hospital logos or something from a health network. And it does generally go into the detailed checkboxes of what they want. So it's a little nicer than an advanced directive where you're trying to sift through what looks a lot like a contract. But it's a little more detailed than our standard out-of-hospital DNR forms that say don't do any of the above. So as you can see here on a most or pulsed form, it says, do you want resuscitation, yes or no? Do you want comfort measures, any additional measures? Do you want antibiotics, yes or no? Do you want a feeding tube or IV fluids or things like that? So again, this helps the patient delineate exactly what they would want as opposed to what they wouldn't want. and allows them to be a little more specific. And if you find this and it looks filled out appropriately, then you can honor these wishes as if you were carrying out the delegated orders that are on that form. All right, next up is this concept of non-invasive positive pressure ventilation. So non-invasive positive pressure ventilation is sort of a mouthful word, and really what we're talking about is there's two types of non-invasive positive pressure ventilation. One is continuous positive airway pressure, or CPAP. This is what you're used to, right? So we've been using this for a number of years now and having good outcomes with our patients. But there's a second type of NIPPV, and that's bilevel positive airway pressure. So what's really the difference? Well, in CPAP, you have a single setting, right? So we set it to a flow rate, and it gives positive end expiratory pressure. And really what that means is there's a continuous flow of pressure, and at the end of expiration, that CPAP, that PEEP, helps keep those alveoli open at the end of expiration, whereas without the PEEP, they may close. And your alveoli being responsible for your oxygenation, by keeping those open, you're actually assisting the patient's ability to oxygenate. So if you have a hypoxic patient, especially if they're not hypercapnic, this is where CPAP really comes in. But bilevel actually has two settings. It has expired positive airway pressure, which is known as EPAP, which for whatever reason is just another acronym for the exact same concept of PEEP or CPAP. And then it has inspired positive airway pressure, or IPAP. And what that does is that it senses when the patient is breathing in. And when they breathe in, it gives some pressure support. It actually helps open up the actual airways and gives an extra bit of pressure during that inhalation. And then during exhalation, it keeps that minimum EPAP level like your CPAP device. And so what this does is it actually increases the patient's tidal volume. So whereas it also opens the alveoli and helps with oxygenation, during that inspiration, it increases their tidal volume and it actually assists in their ventilation. So it actually can help blow off CO2. It can help the patient take a bigger or deeper breath in. And so this works really well for your hypercapnic and hypoxic patients. And if they're hypercapnic but not hypoxic, this is also still a great solution for them because you want that tidal volume to be able to blow off some of that CO2. So there's a few differences with the devices that we're going to be using. Slowly, the system will move from the FlowSafe 2 that we have right now, which is a CPAP-only device, to the FlowSafe 2 bilevel, which is a bilevel device that also has a CPAP function. And so if you have a CPAP-only device, then just use the CPAP-only device. If you have the bilevel device, CPAP is good for when you need to titrate the pressures, if you need to give inline nebulizers, which I'll touch on in a second. And really, if you have, for example, let's say a COPDer who has good tidal volumes and they're wheezy, but they're ventilating well and they're maybe a little hypoxic, then that's where CPAP can actually help. Bilevel is not titratable, and you can't use nebulizers through it based on the way or due to the way that the device is actually set up. So let's say you have a patient in severe distress who's breathing on their own spontaneously, but having significant respiratory distress and maybe isn't getting as good of a tidal volume as they need. That's where bilevel can come in handy. And so again, it doesn't really matter what the underlying disease process is. I did talk about COPD and CHF in these examples, but you can use them in other diseases. It really depends on what you're really aiming to achieve. In general, if you have a bilevel device, you can probably start with bilevel and see how the patient goes, and then titrate if you need to back to a CPAP. This is a picture of what the device looks like. It is very similar to the FlowSafe 2 that we have now. It's made by the same manufacturer. What you'll see on the end there is a little green knob, and basically the green knob switches you from CPAP mode to bilevel mode. We're going to cover all this in the next CE where we do some hands-on training with this. But basically, due to the way that it has to sense inspiration, you can't use nebulizers through it. You have to set the IPAP pressure first and then turn it on, and that'll drop down to the EPAP pressure. So we'll cover all that in the next sessions, but just be aware that this is coming. All right, a quick reminder about the crashing patient protocol. So again, the goal of the crashing patient protocols is you can use it on every patient. If you show up and you run them through the algorithm of the crashing patient protocol, most patients will just fall all the way through. They'll have met their goals immediately, and you can move on. But really, the patients that we're trying to target are the ones in extremis, right? So you show up and you're like, man, they are sick. They're altered, or they've got airway issues, or they're in bad respiratory distress or failure, or they're in shock, or they look like they have poor perfusion, or they look like they're probably going to go into cardiac arrest soon. those are the patients we're aiming to sort of use this protocol on. So again, remember, when you recognize that, right, the first thing, take a deep breath, get ready. You're going to work this patient and you are going to resuscitate them to stabilize them to move them to the ambulance. For a patient like this, the ambulance is there for you to transport them, not for you to resuscitate them. So again, don't move them to the ambulance. Don't start transporting just because the patient's sick. The goal is to assess them. Let's work towards these goals in a unified fashion and get them stable enough so that we can move them collectively together. As a reminder, the respiratory and circulatory goals, as well as the exit strategy. And one of the videos after this one, you're going to hear from Dr. Miller going over the new pediatric crashing patient protocols that have very similar goals, but flow in a slightly different direction. And again, I really want to stress this. The point of the crashing patient protocols is to help us work as a team to standardize our approach to these critically ill patients. It takes everyone being on the same page, working together to meet the goals in order for us to be successful. So again, I implore everyone, let's work on this together. Let's move this forward as a system, and let's really try and help our patients. All right, so we made a few changes to the TXA protocol in this update, and I want to go into a little bit of the medicine as to why. So there were two questions that we really liked out of a proposed TCCC guideline change. One was, should we add a TBI indication? And should the dose be increased to 2 grams as well? And then can we actually just push it as opposed to mixing it into a saline bag and having to run it over a pump or running it over a period of time? And so we're going to answer sort of both of those questions with a little bit of science. So back in 2012, when some of the original research on TXA was coming out, there was a study that basically said, hey, look, TXA could actually probably help TBI patients, but we don't have enough data yet, so we need to start some research. And then 2 years later, another study came out that wasn't looking exactly at TBI, but it basically said, hey, looks like intracranial hemorrhage from trauma, the progression of that decreases when you give TXA, and so maybe this can help patients who have a TBI. 2019 was really the first paper that came out, CRASH 3, that looked specifically at TBIs for using TXA. And they found that they had a really mild reduction in mortality, as well as when you look at the sort of mild to moderate patients who weren't GCS-3 or didn't have like severe head trauma, they actually found an overall mortality increase by a couple percent. But this year, the ROC TXA TBI trial came out, and a lot of you may remember we were a participant in the ROC TXA TBI trial. And remember, it was a randomized controlled trial, and it looked at placebo versus our standard dosing, which was a 1 gram bolus followed by a 1 gram 8-hour infusion versus a 2 gram bolus. And what they found was that there was a significant reduction in mortality in that 2 gram group, 18% compared to 28% in both of the other groups. And when you dive through all the data and everything else, it really boils down to this. If you have a patient with a head injury and they can't follow command, so that means their GCS motor score is a 5 or less, all right, then they will probably benefit from some TXA, and they're probably going to benefit from 2 grams as opposed to 1 gram. So we're going to be doing a couple things. One, we're going to add an indication for TXA for those with a closed head injury who can't follow command, so a motor GCS score of 5 or less, and then we're going to increase that dose from 1 gram now to 2 grams. And then when you go into some of the other research about whether it really needs to be given as an infusion as opposed to a push, some of the original data, like in Matters, used an IV bolus, and then there's some real life experience from a lot of the military using IV boluses instead of a drip. And in general, there's not been any deleterious effects. And so what we're also going to be doing is changing it to an IV push over a minute as opposed to an infusion. So when you look in the protocols, you're going to see the updates. So you still have your traumatic indication, so significant hemorrhage and a blood pressure less than or equal to 90, or a heart rate greater than or equal to 110 with poor perfusion, or a TBI with an inability to follow verbal commands. That's a motor GCS of less than or equal to 5. In the current draft you have, it may say less than 5. That's a typo on our end. We will fix that in the final version, but it'll be a motor GCS of less than or equal to 5. Give TXA 2 grams, either IV or IO, not IM, as a slow push over 1 minute, all right? And again, that same time cutoff, that if it's over 3 hours from the onset of injury, go ahead and don't give it because there's some increase in harm after that point. All right, let's talk about push dose epinephrine. So all the paramedics here are aware right now we have really two vasopressor options. We have norepinephrine infusions and we have epinephrine infusions, right? The problem is both of them have to be mixed, right? So you have to find a saline bag, you got to inject the medication, you got to shake it up, and then you got to put it on a pump, right? And then even though we're increasing the starting dose in this update, infusions take a little while to kick in. You got to actually let them run in and actually let the blood start circulating in order to get an effect. And the reality of it is this is sort of hard to do on scene, right? So we're pushing this concept of crashing patient, of saying, hey, you need to get these patients' blood pressure up before you manage their airway and get them stabilized before you move them. But then we asked you to take this giant pump into the house with you and do all this mixing at the bedside and everything else. So what we're going to do is add in push dose epinephrine into the system. And this is going to do a few things. One, it's going to be at the assist level. So whether you're an FRO paramedic or a MedStar paramedic, you're going to be able to do this at the bedside in the home. It doesn't require a pump. It's a relatively easy mixing process. And it works really well for your critically unwell patients. So again, we're going to cover this in the hands-on CE that's coming next quarter. But essentially, you take a 10 ml saline flush, you squirt out 1 ml of saline, so you have 9 mLs of saline. You draw up 1 ml of your code epinephrine, which is your 1 in 10,000 epinephrine. And that gives you a 1 in 100,000 solution. So you've got 10 mLs and it's 0.1 milligrams per ml. So this is going to work for a lot of great clinical indications. So let's say you've got a septic shock patient that isn't quite at their blood pressure goal yet before you move them to the ambulance. Or you've got a patient with a peri-intubation hypotension and you want to support their blood pressure so it doesn't tank when you intubate them. Or you've got a post-ROSC patient that you're trying to stabilize on scene and package them up, but their pressure and heart rate slowly keep dropping. This is a good temporizing solution until you can get to an infusion. So that's how it's written in the protocol. If you have persistent hypotension despite adequate fluid administration and to temporarily stabilize the blood pressure until you can start an infusion, then you can use the push dose epinephrine. So again, it's a 0.1 milligrams in 10 ml solution, and you're going to give 10 micrograms. So that's 1 ml, all right? And you can give that every 5 minutes or so up to a max of 5 mLs, all right? And again, remember, this is strong epinephrine. It is IV, and using large doses in rapid succession doesn't usually go very well. So titrate it slowly, but it will have a good impact even with 1 ml at a time. And remember, this is a temporizing solution. If you are giving push dose at the bedside, you should start an infusion in the ambulance. The underlying cause is probably not fixed, and that epinephrine that you give as push dose will wear off. So by the time you are stabilized and now in the truck and starting your infusion, that epinephrine will start to wear off. So you want to make sure that there's some more vasopressor circulating, whether it's an epinephrine infusion or a norepinephrine infusion, depending on the indication. And the last big change we're going to talk about is the addition of ketorolac or Toradol. Right now, we really only have two pain management options. We have acetaminophen or Tylenol for those with a pain score less than 6, or we have IV fentanyl for patients with a pain score of greater than or equal to 6. And in reality, we were looking to add a sort of non-narcotic parenteral analgesia for someone who needs pain medication but is better served by a non-narcotic but either can't take pills or needs another option. So in those instances, ketorolac is a great drug. So what is ketorolac? Ketorolac is a non-steroidal anti-inflammatory drug, or an NSAID. It's like ibuprofen or naproxen, but it's given IV or IM, and it works really well. It does have a little longer time of onset, so it takes roughly 30 minutes or so to see a real impact with a peak effect of about 1 to 2 hours. And it lasts 4 to 6 hours, so that impact will last into the hospital stay, which is great. It does have some adverse effects, but they're pretty rare and usually happen at much higher doses than we're going to be using. In general, you can see things like abdominal pain, nausea, headache, but again, I don't think those are really things that we're going to see while we're giving it pre-hospital. Importantly to know, ketorolac does have some adverse effects on the actual patient itself. So it comes with some platelet inhibition, so for patients who are bleeding, that may cause issues. It affects bone remodeling, which can come into play if you have a patient with a fracture. And if they have existing renal failure, it can actually worsen that as well. So we've listed out a set of contraindications in the pharmacopoeia, and the main things are obviously a hypersensitivity or an allergic reaction to ketorolac, anything that has to do with bleeding. So active peptic ulcer disease, recent GI bleeding, any bleeding of any kind that you can think of, don't give any ketorolac. Anybody with bad renal failure, so if they have a history of renal failure, don't give it to them. If they're pregnant or in labor or breastfeeding, don't give it to that because of how NSAIDs act on the fetus or the infant. And then really for patients in shock and hypotension, we don't really want to use it for that either because those patients can end up developing renal issues into their hospital stay, and we don't want to make it worse with ketorolac. And then the last one on here especially about the bone remodeling is, remember, if you've got a patient and you're pretty sure it's fractured, like it's open or it's deformed, then probably avoid this and stick with your IV opiates. One, you'd want that if you were in their situation, but two, it does affect the bone remodeling a little bit, so we don't want to use it. An easy rule of thumb is if you think this patient's bleeding, or if you think they might need surgery, or if you can see their bone sticking out, probably don't use ketorolac. All right, so that's really it for my section. Those are the big changes. And again, I really want to implore you, if you have questions about anything that we're going to cover today, anything you saw in the protocol update, in the last video, in the draft itself, we've gotten a couple questions by email. You can send them to email. You can email me directly. You can come up to our office. We'll hopefully be holding some town halls here as well to help have some live Q&A sessions as well. Again, I really appreciate everyone's flexibility and especially with the short notice of switching to a virtual CE. I appreciate everyone's patience, and I really look forward to seeing you all again soon in live CE. So I'm going to hand it off to the rest of the OMD team, and they're going to take you through the rest of today's CE.